Hello everyone, welcome to the channel. Today we are going to discuss one of the most important and challenging condition in the modern obstetrics, that is fetal growth restriction. It is also known as intrauterine growth restriction, FGR or IUGR. A baby who appears small on scan is not always growth restricted, and a growth restricted baby may face serious risk including the stillbirth, fetal hypoxia, neonatal morbidity and long-term health complications. The key challenge for every obstetrician is differentiation of a constitutionally small fetus from a truly growth restricted fetus. So in this video we will discuss the latest guideline based approach, including the definitions, the diagnosis, the Doppler assessment, surveillance and the timings of delivery. Now FGR is the common pregnancy complication that worldwide is the leading cause of stillbirth, neonatal mortality and the short-term and long-term neonatal complications. The cumulative risk is approximately 1.5% at fetal weight less than 10 centile and increases to 2.5% if the gestational age fetal centile is less than 5th centile. The risk of stillbirth was highest among the fetuses, estimated to be less than 3rd centile for growth. So, as the centile decreases, the risk of IUD, that is stillbirth, increases. Now there are certain complication or the risk associated with this FGR babies. So antenatally these babies can have stillbirth, preeclampsia in the mother, placental abruption, preterm birth. Short-term complication includes the perinatal mortality, birth asphyxia, RDS or the respiratory distress syndrome, necrotizing enterocolitis or the NEC, newborn encephalopathy, intraventricular hemorrhage, infections, hyperviscosity syndrome, hypoglycemia, hypocalcemia. While the long-term complications in these babies are the metabolic syndrome, cardiovascular disorders and the psychotic disorders. Now how will you define FGR? So you have two babies from the two different families, and one baby is meeting the growth potential of his family but not the other. So FGR is defined as the failure of the fetus to meet its growth potential due to a pathological factor, most commonly the placental dysfunction. Now there are two terminologies, which is small for gestational age when the estimated fetal weight or the abdominal circumference is less than 10 centile, and fetal growth restriction. So if the fetal weight and abdominal circumference is less than 10 centile, this is SGA. We have not done the color Doppler yet. And if the fetal weight is less than 3rd centile or the abdominal circumference on the lower side, that is less than the 3rd centile, then this is fetal growth restriction. Estimated fetal weight or the abdominal circumference less than 10 centile with color Doppler changes. So 10 centile along with color Doppler changes is important, or the growth velocity drop is more than 2 quartiles or the 50 centiles. Not all small babies hence are growth restricted. This definition for small for gestational age tells that if the ultrasound is normal but the estimated fetal weight is less than 10 centile, then these babies are small for gestational age and these small fetuses are not growth restricted. Now there are two terminologies, that is early onset fetal growth restriction or the late onset fetal growth restriction. If early onset FGR and late onset FGR. So this terminology depends on the gestational age. If the onset of fetal growth restriction is detected at less than 32 weeks of gestation, this is early onset FGR, and if the late onset FGR means when the growth restriction is detected after 32 weeks of pregnancy. The rationale for such classification is based on the differences between these two in severity, natural history, Doppler finding, association with the hypertensive complication, placental findings, and most importantly the management also differs. Now these are the differences. First one we have already discussed, that the gestational age is less than 32 weeks in early onset, and late onset gestational age is more than 32 weeks. Now the definition is same, that is estimated fetal weight or the abdominal circumference is less than 3rd centile. Now coming to the color Doppler changes, in early onset FGR the umbilical artery shows the changes first. So umbilical artery is having an absent and diastolic flow. Okay. and if the gestational age is if the abdominal circumference or estimated fetal weight is less than 10 centile and the changes are seen both in the uterine and umbilical arteries, then this is early onset FGR. While in late onset FGR, abdominal circumference or estimated fetal weight is less than 10 centile, drop in the growth velocity by more than 2 quartiles or 50 percentile, and the CPR, that is cerebroplacental ratio, is 5th centile se kam, or umbilical artery is more than 95 centile. So here either the estimated fetal weight is less than 3rd centile, or if the estimated fetal weight is more than 10 centile, then 2 out of 3 should be possible. That is abdominal circumference, sorry, not more, estimated fetal weight is less than 10 centile, drop in growth velocity, and CPR or umbilical artery changes. So these are the definitions or the differentiating factors between these two conditions. Now coming to early onset FGR, the incidence is very less, prevalence is just 0.5 to 1%. But if this occurs, then this is very severe, and the Doppler changes are very evident as compared to the late onset FGR. In late onset FGR, the Doppler changes can be absent also. The underlying placental, here the defect lies within the placenta, and the features are similar to early onset preeclampsia, which explain the strong association between these two conditions. It is easier to detect, and natural history tends to follow predictable sequence of the Doppler changes. So initially the changes comes in the uterine arteries, then umbilical arteries, then your MC or the middle cerebral artery, ductus venosus, and then the baby dies. The main challenge is the management, because the fetus is not mature. Hence, by attempting to determine the optimal balance between opposing the risk of stillbirth, so if we leave this pregnancy as it is and we do not take any step, then this baby can die in utero, or if we deliver this baby, then this baby can land in prematurity also. So we have to balance these two conditions, and hence the main challenge is the management. Now for late onset FGR, the prevalence is 5 to 10%, means late onset FGR is more common. It is usually milder because rest of the systems have already developed, and it is less associated with preeclampsia, and here the umbilical artery Doppler can be normal also. Hence the main challenge is in its diagnosis, because Doppler changes are absent, only fetal weight is on the lesser side. Hence the main challenge is in the diagnosis, while management is relatively simple, as the diagnosis is commonly made during the late preterm or at term, where the risk is associated with delivery are relatively small. So here the main challenge is diagnosis. We can deliver these babies and they have good viability also. The diagnosis mainly relies on the adaptive changes, which is reflected by the low resistance to flow in the middle cerebral artery and thereby generating a low CPR. So these are the differences. First one we have already discussed. The prevalence of early FGR is 30%, while most of the cases are seen in the late FGR. So 70-30 ratio is there, and hypertensive disorders ka association is more with early FGR. Placental pathology is more with early FGR, just like preeclampsia, perinatal mortality, because fetus is premature also, and there is high chances of stillbirth. So perinatal mortality is high with early FGR and it is low with the late FGR. Perinatal Doppler changes are more in early FGR. Spectrum of Doppler alteration from umbilical artery to middle cerebral artery to ductus venosus are seen, while here in late FGR cerebral blood flow redistribution is seen, and hence the CPR is less than 5th percentile, while the umbilical artery is more than 95 percentile. In early FGR the main challenge is the management, while in late FGR the main challenge is in its detection. Now coming to normal growth, fetal growth. So there is some genetically predetermined growth potential within the fetus, and fetal health, placenta, whether it is normal or abnormal, mother maternally patient is normal, maternal health is okay, and maternal nutrition is very important. So the fetal growth occurs by cellular hyperplasia up till 16 weeks. Then from 16 weeks to 32 weeks there is both hyperplasia and hypertrophy, and then after 32 weeks only cellular hypertrophy lasts. So hyperplasia reduces and hypertrophy, there is shifting of hypertrophy from 16 to 32 weeks. So first hyperplasia, then hypertrophy plus hyperplasia, and then hypertrophy. Now there are certain etiologies for fetal growth restriction or the causes. We have divided the causes into the maternal factors, which are pre-placental factors, the placental factors, and the post-placental factors. सो सब ऑप्टिमल यूट्रो प्लेसेंटल परफ्यूजन ऑफ द फीटल न्यूट्रिशन, मतलब जो यूट्रस मतलब प्लेसेंटा से जो बच्चे को न्यूट्रिशन पहुंच रहा है वो सब ऑप्टिमल है, मतलब कम है. सो फर्स्ट वन इज द cause which is maternal in origin or the preplacental disease if mother is having any condition like chronic lung disease or high altitude. So in these two situations there is hypoxemia or the oxygen saturation is lesser, anemia same reason, then smoking or substance abuse, this causes vasoconstriction and placental atrophy also. So these two conditions are associated with fetal growth restriction. Malabsorption or poor weight gain, environmental toxins like air pollution, heavy metals, lead and mercury, perchlorooctanoic acid or PFOA. So the maternal and the placental factors are hypoxemia, anemia, smoking, substance abuse, malabsorption, poor weight gain, environmental toxins. Now coming to the placental factors includes the maternal vascular malperfusion pathology. So placental factors includes when there is defect within the placenta, either placental infarction, fibrin deposition or the chronic abruption. So this cuts the blood flow from the placenta through the fetus. So this is known as maternal vascular malperfusion pathology. Then there can be, if maternal vascular malperfusion pathology is there, then there can be fetal vascular perfusion pathology also. Means the fetal side of the placenta is having some abnormality. Chronic placental inflammation is also known as velitis of unknown etiology. Confined placental mosaicism is there. And the third cause is the umbilical cause. Umbilical cause means the post placental cause. Post placental means post placental we have what? Umbilical cord. ठीक है, तो umbilical cord में there can be increased coiling, increased cord length. So the coiling can be increased. So the normal coil length is 35 centimeter. So if this cord length is more than 50 centimeter, then this is abnormal, or if this is less than 15 centimeter, then this is the short coil or short umbilical cord, then this is also abnormal, increased number of coils. So there so per turn if the coiling is increased or there are so many coils, true cord knot, single umbilical artery, marginal or the filamentous cord insertion are the causes that are post-placental in origin. Now, these are the maternal causes which are divided into pre-placental, placental and the post-placental. Then fetal disorders can be there, like genetic disorders which can be chromosomal in 5% of the cases, microdeletion duplication, single site mutations, epigenetic disorders, structural abnormalities like congenital heart diseases and gastroschisis which impairs the absorption or congenital heart disease in the baby. Congenital infections can be there in 5% of the cases like cytomegalovirus, toxoplasmosis, herpes, rubella, syphilis, Zika virus, malaria and teratogenic exposures like drug and the toxins. So the fetal disorders includes the genetic disorders, structural abnormalities, congenital infections, teratogenic exposures. Now placenta and its adaptation. So placenta provides oxygenated blood to the fetus in low resistance circuit. Adaptation by waves of trophoblastic migration which is known as the trophoblastic invasion, and this trophoblastic invasion these trophoblastic cells are invaded to the muscular layer of the maternal spiral arteries, hence they convert them from high to the low resistance vessel. So the spiral artery is having two parts, the decidual parts and the myometrial part, and in this condition the decidua gets its trophoblastic invasion but the myometrial part of the spiral artery does not. So the first wave occurs at 6 to 12 weeks where there is intradecidual segment of the spiral artery which is getting trophoblast invaded. Second wave occurs at 16 to 18 weeks in the intromyometrial segment of the spiral artery, and because in preeclampsia this wave is abnormal or in IUGR this wave is affected, so there is decrease in the vascular resistance and less responsiveness. So what these trophoblastic invasion do, it decreases the vascular resistance and responsiveness to the local vasoconstricting agent, while if this trophoblastic invasion fails then this can lead to fetal growth restriction as well as the preeclampsia. So you can see this diagram, and in this diagram you can see that the uterine artery is dividing into arcuate ARBS. So we have to ARBS, ठीक है. So arcuate artery, radial artery, basal artery, spiral artery, and the spiral artery is present in the endometrium. This spiral artery is having two parts, that is the decidual part which is lying in the endometrium and the myometrial part. So in the first phase this decidual part gets its trophoblast, and in the second phase this myometrial part gets its trophoblast trophoblast at around 16 to 18 weeks, and if this is absent, so the preeclampsia can arise. You can also check in the second diagram where there is syncytotrophoblast and the cytotrophoblast. The extravillous trophoblast lines the vessel, the spiral artery, and in preeclampsia the endovascular extravillous trophoblast is not covering this part of the spiral artery, and hence preeclampsia is occurring. Now there are certain predictors of the FGR. These are the history based predictors. This can be age. So if the age is on the extreme side, so either the female is lesser in age or more in age. So definition at risk more than equal to 35 to 40 years, and even at lesser age means less than 18 years is also susceptible to fetal growth restriction because the nutrition is not yet completely possible. Now coming to parity, nulliparous females, primigravidas are more at risk. BMI, either patient is undernourished or obese, that is BMI less than 20, more than 30. So on the right side we have written the odds ratio. Now maternal exposure, 1 to 10 cigarettes per day, more than 10 cigarettes per day, or the cocaine abuse. So cocaine abuse is also associated with fetal growth restriction. IVF, singleton pregnancy. So if the mother has conceived by IVF and this is the singleton pregnancy, exercise, daily vigorous exercise, low fruit diet. Now for SGA, so if if the baby's mother is SGA, then the odds ratio is 2.6, and if the paternal side means his father is also having small for gestational age, मतलब माँ भी अपने बचपन में स्मॉल फॉर जेस्टेशनल एज रही होगी या फादर भी उसका स्मॉल फॉर जेस्टेशनल एज रहा होगा, तो उससे भी हमारा रिस्क इंक्रीज करता है. Then coming to the conditions, the medical history is important because this can be hypertensive patient, diabetic patient, kidney disease patient, or APLA. So APLA is also associated with fetal growth restriction, preeclampsia, and IUD, and here also hypertension, diabetes, CKD, and APLA. Now coming to previous history, if previous baby is also SGA, then risk is odds ratio is 3.9. Previous history of stillbirth is there, previous history of preeclampsia is there, and the period interval means inter-pregnancy interval. If this mother has conceived within 6 months of the last delivery, or if the duration is more than 5 years or the 6 months. So if the difference is more than 5 years or 6 months, then this is also a risk factor. If there is history of threatened abortion in this pregnancy, Down syndrome screening is positive, then USG finding showing echogenic bowel, pregnancy induced hypertension, preeclampsia we have already discussed, low maternal weight gain. This is more important because if mother does not gain weight during pregnancy, which is a risk factor, unexplained antepartum hemorrhage. Now there are certain ultrasound based markers. Ultrasound based markers means you have done an NT-NB scan, and in the NT-NB scan the uterine artery changes. You can see the uterine artery changes like the uterine artery which has a PI. PI means pulsatility index. The pulsatility index of the uterine artery is more than 95th centile, or the uterine artery PI at 11 to 13 weeks predicts 60% of the preterm and 17% of the small for gestational age at false positive rate of 10%. Now coming to the placental causes, the type of placenta. If the placenta is marginal or filamentous cord insertion is there, 2 vessels in the cord means single umbilical artery. Usually we have 3 vessels in the cord means 2 umbilical arteries and 1 umbilical vein is there. But here if there is just 1 umbilical artery, then this can be associated with fetal growth restriction, abnormal placental morphology, or the texture. So these are the ultrasound based markers. So first we have seen what? History based marker. Then we have ultrasound based markers like the uterine artery and the type of placenta. Then we have some biochemical markers also like PAPA and PIGF. So if pregnancy associated plasma protein A or placental derived growth factor is lesser, then this can be associated with adverse outcomes including SGA, and these two are also the screening markers for preeclampsia. Elevated second trimester alpha fetoprotein HCG levels greater than 2.5 mom are associated with FGR and stillbirth. So these two proteins, H for higher, so HCG and alpha fetoprotein, which are also the marker of Down syndrome, if they are elevated, the combination of The combination of low PAP-A in the first trimester and high alpha-fetoprotein in the second trimester is particularly predictive of severe FGR, and no evidence to support the routine use of biochemical markers for the prediction of FGR. So we do not do them routinely, but they can be done. Now for detection of FGR. So first we have seen the history based markers, and we can do USG also. We have biochemical markers also, but after taking the history, we have to identify the risk factors for both fetal and the maternal side, and we have to check the history of failure to gain weight and the decreased fetal movements. On examination, per abdominal examination, when we check her uterus, the uterus feels small for the gestational age, and if the symphysiofundal height is less than 3 centimeter or the gestational age is less than 3 weeks, then this is fetal growth restriction. Slow or static symphysiofundal height is there, and liquor can also be inadequate. Now what is symphysiofundal height? Symphysiofundal height is the simple, inexpensive, widely used method for screening of fetal growth restriction. So we have the SFH, also known as the symphysiofundal height. So the important point is that it is measured in centimeters, and the gestational age at which we can check this accurately is 24 to 38 weeks. So after this 24 weeks, we can check the symphysiofundal height. The sensitivity is 58%, and reverse this, that is 85% is its specificity. So the sensitivity is lower but specificity is more, and predicting birth weight below the 10th centile. Now there are certain prerequisites. Can anybody tell what are the prerequisites? Yes. So this is to be measured between 24 to 38 weeks of pregnancy. We have checked this. The bladder should be empty. There should not be any fibroid. There should not be macrosomia or polyhydramnios, and the inch tape should be placed between xiphisternum to the pubic symphysis to check the symphysiofundal height, and hence its name. Now dating scan can be done, and dating scan detects the gestational age accurately if done in the first trimester. And when we have to check this, when the CRL is between 7 to 60 mm and best is at least 10 millimeters. Accurate dating of pregnancy is very essential because patient can be forgetting her last menstrual period, and hence we are falsely detecting fetal growth restriction based on her incorrect LMP. Establish gestational age with the precision of 5 days in 95% of the cases in case of dating scan at first trimester. Now detailed anomaly scan should be done to detect any structural anomaly, aneuploidy or the fetal infection signs, because these etiology are responsible for fetal growth restriction in the fetal factors. Now USG can also detect fetal biometric parameters, and it is the cornerstone for detection of fetal growth disorders. Standard biometry includes the abdominal circumference, the head circumference, the biparietal diameter, the femur length, and the accuracy is around 10% with error greater at extremes of age. Use of headlock formula by 3 indices provide great accuracy. So 3 parameters we use for this. What are these 3 parameters? 1 minute, I am telling you what are these parameters. So standard biometry headlock formula has. So what is headlock formula? This is the formula is used in the USG machines to calculate the gestational age of the baby, and this include, so this headlock formula checks the estimated fetal weight by using the BPD, the head circumference, the abdominal circumference. So you have to remember two circumferences, that is the head circumference, abdominal circumference, and one parameter of the head, which is known as the biparietal diameter. And which parameter is not used? Femur length is not used. Now coming to the third trimester USG, routinely we do not advise the third trimester ultrasound to assess the fetal growth, but if needed, or if you are suspecting fetal growth restriction or decreased Leica or abnormal growth or Doppler abnormality, then you have to advise it also. Now there are certain indications or the uses of third trimester scan. What are the indications? So presentation can be checked. It can also be checked through palpation, but ultrasound offers confirmation fetal anatomy. There can be some anomalies which can be missed in the second trimester scan. So third trimester scan can detect such fetal anomaly and fetal growth for checking the Leica, for doing the Doppler and placental localization, because the management depends on the placenta. And if there is signs of adherence like placenta accreta, increta or paraccreta, then we can also detect that from or during external Catholic version. And pregnancy dating, in pregnancy dating it is less commonly used, but if patient is having no antenatal scan, then we can advise her a scan. Reduced fetal movement and antepartum hemorrhage, investigate causes of bleeding, placental abruption or the placenta previa. Rupture of membrane and ECV we have already discussed. So this is the use of the third trimester USG. Now there are certain additional tests for infections like serological testing and CMV toxoplasmosis. If severe FG is there, we can also check for syphilis and malaria. APLA screening, amniocentesis can be done, but these are not routine. Now coming to the management of fetal growth restriction, in cases of FGR is due to fetal abnormalities, either genetic or infectious causes, the management should be individualized and there is no effective antenatal treatment for placental dysfunction. We have to tell the patient that she has to see the daily fetal movement count, and this is a simple inexpensive tool which can be told to the patient for monitoring in OPD basis. Progressive fetal hypoxemia is accompanied by reduction in the fetal activity, and this activity can be perceived by the mother only. So normally the fetal movement that we have to explain is that fetus should at least move 10 movements in 2 hours during focused maternal count. So if she is lying for 2 hours and she is focusing whether my fetus is moving, baby is moving or not, so in the focused setting at least 10 movements in 2 hours should be there, and in a non-focused setting in 24 hours 10 movements are normal, and if this is reduced then this is abnormal. Now there is another test which we can do. This is cardiotocography, also known as the non-stress testing, which is a universally recommended tool to monitor the pregnancy complicated with FGR, and the reduced variability is very strong predictor of central nervous system hypoxia. Now CTG, we can do this at more than 29 weeks, below 4 millisecond and or below 3 milliseconds. So if this is FHR variability, so if the FHR variability is below 4 millisecond or below 3 milliseconds, it meets the criteria for reduced or low STV respectively, and if the gestational age is less than 29, then the STV below 3.5 is considered reduced, and below 2.6 is very low. Now AFI can be checked because if in case of growth restricted fetus, the kidneys are also growth restricted and hence there is fetal oligouria. This can lead to progressive placental in response to progressive placental dysfunction and hypoxia, as well as there can be rupture of membrane also. So ligohydramnios is associated with an increased rate of intrapartum fetal heart abnormalities, need for cesarean section, and a low 5-minute Apgar score, but not acidosis at birth. Now there is one tool then we can advise with the USG. This is known as the Manning score, also known as the modified biophysical profile. The biophysical profile scoring is universally recommended as the primary surveillance tool. The score is 8 to 10, 6 or 4 or less than this considered normal. 8 to 10 is normal, 6 is equivocal, 4 is 4 or less than 4 is abnormal. And in unselected pregnancy, the rate of stillbirth following a normal BPP is 0.8 per 1000. So an abnormal BPP is associated with umbilical pH of less than 7.2, that is fetal acidosis. So this is the modified biophysical profile, and we have to remember it. So first one, so the mnemonic is TB, meningitis, always, notorious. T for tone. So the point, so the score is either 0 or 2. Okay. So the gross body movement. So T for tone. Tone means if, so we have to check this segment again. सो हाँ ठीक है. तो ज़ीरो कब बोलेंगे हम, जब हमारा टोन की बात करेंगे अगर हम, तो टोन में अगर हमारा स्लो एक्सटेंशन एंड द रिटर्न टू फ्लेक्शन मूवमेंट लिम एक्सटेंशन एब्सेंट. सो इफ देर इज नो मूवमेंट देन दिस इज 0. and how many movements are required? At least more than one episode is required. So more than one episode of extension and flexion of the fetal extremities is not considered normal. B for breathing. So if the breathing pattern is not there, so if the fetus is not breathing or no episode for more than 30, so we have to check this for 30 minutes. And if there is no episode of breathing, then this is 0. And if at least there is one episode of 30 minutes of breathing or hiccups, then this is known as score of 2. Then M for movements, but here the movements are gross body movements. So if there is no movement at all in last 30 seconds, or if there is no movement at all, या फिर लेस देन 3 मूवमेंट्स आर देयर, मीन्स कम है मूवमेंट बच्चे का, देन दिस इज गिवन अ स्कोर ऑफ 0. and if there are 3 or more than 3 gross body movements, limb movements in 30 minutes, episodes of active movements, a single movement is counted as 1. So this is a score of 2. So TB, meningitis, always. A for AFI. So here AFI is measured in terms of the deep vertical pocket, DVP. So if there is more than one pocket of fluid measuring more than 1 centimeter in two perpendicular planes, or if the AFI is less than 2 centimeter. So the deepest vertical pocket is present, then this is given a score of 2. And if there is no deepest vertical pocket or the size is less than 2 centimeters, then this is given a score of 0. And now coming to the last point, that is NST. NST means if the CTG is non-reactive, so CTG is reactive, then this is given wrong in this diagram. So if this CTG is reactive, then the score of 2 is given, and if the CTG is not reactive, then given a score of 0. So the total score is 10. And if we omit the NST, means if there is no CTG, then the score of 8. So 8 or 10, both scores are considered normal. 6 is considered equivocal, and less than 4 is considered as abnormal. So this is the Manning score. Now we can also do the Doppler assessment. So we have 4 vessels that we have to check in the fetus, and we will discuss it later.